Let me invite our other panelists up. Americo, Amir, and Saad, thank you very much. If you'd join me on the stage, we're going to join Sir Andrew here and hear a little bit about your perspectives on a variety of things. So remember the poll in the app as well. We want to make sure we get to that at the end. So for the next 45, 50 minutes, we're going to hear some other perspectives on health technology, and then we're so anxious to talk with all of you about what you're doing and what your questions are on this very, very important topic. So we're going to begin with Professor Americo Cicchetti, Università Cattolica del Sacro Cuore. Not bad? Italy. He is going to talk about hospital-based health technology assessment, and of course, again, this topic of assessment is so very, very important to manage innovation and divestment, right? Sometimes the most strategic decision you make is what you stop doing. So again, we're looking forward to your insights on the way HTA is used for hospital managers and what those methodologies, models, and experiences are. Americo, join us.
Good morning. Thank you very much for this invitation. Very happy to tell you something about a work that started more or less 20 years ago, actually in a hospital that is the hospital of our university in Rome. I'm going to talk about very briefly also about our case study. But in general, of course, hospitals are the main entry point of many health technologies. And healthcare managers need to make strategic decisions in the way that their organizations will be able to extract value from technologies. And on the other side, in a way to maintain a financial balance. Traditional health technology assessment is using a multidisciplinary and multi-stakeholder approach that I've read also behind the discussion, wonderful presentation from Sir Andrew Dillon, to suggest decision-making around health technologies at national level, mainly. And in some cases, such as, for example, in Europe, there are collaborations that are occurring among different countries to produce HTAs that can be used then at national level after an appropriate adaptation and integration of the information to be assessed in order to make decisions regarding the introduction or the disinvestment from health technologies in the single context. Nevertheless, and the value of the health technologies can be proven only when this technology is interacting with organizational variables. Of course, when the technology is interacting with, for example, the kind of professionals that we have in our hospital. The quality of competencies, of course, are fundamental if I would like to extract value from, for example, a surgical robot. Technology innovation, again, here is described, and then I'll be back to the definition of hospital-based HTA, as a cascade, because such a cascade needs to be managed, of course. At any level, at each level, we need to assess diverse combinations of the variable that can affect the impact of a new technology. The risk-benefit profile, at first, this is something that is in charge of the regulatory bodies. Effectiveness, cost-effectiveness, that is very important, has been outlined by Dr. Dillon, but of course also organizational and the broader societal impact, and finally the budget impact that is occurring in our hospitals. And healthcare managers need to be supported in very practical decision makings, for example, procurement. And the issue here is to understand which kind of assessment we need at different levels in order to arrive at the final point of this story. So when we are going to adopt, to buy a specific technology and to introduce this technology within clinical processes in a way that is going to generate the value that we would like to have and to have also the opportunity to maintain a financial balance. Of course, we are not talking here about to redo always the same analysis. Actually, the idea here is to have the opportunity to use the assessment that has been done by regulatory bodies, by HTA agencies, HTA bodies at national, regional level, in order to be more and more effective in making decisions around health technologies at hospital level. I'm going back here because starting from these principles, let's say more than 20 years ago, we have seen a movement, an attempt to apply the logic of health technology assessment to support decision-making, managerial decision-making at hospital level. This is a definition of hospital-based HTA that has been produced thanks to an European-funded project from 2013 to 2016 that involved different countries, different institutions in Europe. And hospital-based HTA is the application of the typical multidisciplinary, multi-stakeholder approach to support managerial decision-making and clinical decision-making at hospital level, using analysis to be done not only at a hospital level, but also at the highest level. Very quickly, just to report what has been done, what we know. We know, for example, that doing HTA at hospital level is not making the journey of the technology to the clinical practice longer, but actually the process is more effective. Doing HTA at hospital don't mean to replicate the assessment in any of the variables of the impact of the technology, but focusing on only those variables that could be assessed at that level. So organizational variables, budget impact are the relevant issues to look at that. And the Adopta project has produced a lot of tools. We have a toolkit. We have, in particular, this mini HTA template that is ready to use, is a structure, is a format, is a checklist that can be used by clinicians or by these small groups of clinicians and health economists that could gather in a hospital to support decision-making of managers. 32 questions to be answered regarding each health technology that has characteristics, specific characteristics that suggest an accurate assessment. This is what has been done for 20 years by now by my hospital in Rome. Is a huge teaching hospital with around 100,000 discharges per year. We produce very few full reports, many mini HTAs, more or less 5 mini HTAs per month. Regarding specific technologies, we have a process in place that this is the basic structure. So we try to assess the needs from our clinical departments. These needs are scrutinized by this unit. The unit is producing mini HTA reports that are submitted to committees, one for drugs and medical devices and the other for medical equipment, trying to get the final results. And just to close, of course, doing HTA at the hospital level can create a lot of opportunities, better clinical outcomes, maintain financial equilibrium, to have clinicians involved in the decision making regarding health technologies, of course, is important, but there are some risks to be avoided: duplication of efforts, potential health inequalities, and the quality of the reports that could be too poor if the competencies are not in place. As I said, in Adopta website you can find many tools, a lot of information, but also there is one of the volumes of the World Hospital Health Service, that is the Journal of International Hospital Federation, that has been dedicated to this topic. So this is my invitation to have a better look to the tools with more details that I was able to give you in probably 80 minutes and not 7. Thank you so much. Thank you.
Obviously, there's a lot to be said here, so thank you, Americo. We really appreciated that. Our next speaker is Professor Amir Takian, and he is the chair of the Department of Global Health and Public Policy at the Tehran University Medical Sciences in Iran. And this is really about an important topic of creating the environment for innovation, because obviously, no matter what tools you have, if you don't have the right environment, you can't get anything done. So he's going to talk about some strategies in public teaching hospitals that Iran took to pave the way for fostering innovation, with a particular focus on hospitals. So, Amir, let's invite you to the podium.
Good morning. Thank you, Deborah, and thank you, the IHF, and particularly the head of the scientific committee, Professor Abbas, for inviting me to this beautiful city. And I have a pleasure to share with you some kind of dialogue, as Sir Andrew mentioned, in terms of how we can foster innovation. When we talk about innovation, some parts is technology, but more important than technology is the governance and the environment that we are creating to have and to foster innovation. So I'm going to bring some kind of general thoughts for more dialogue among ourselves, how we can foster the innovation, and then in the end I bring some kind of very simple examples from my own country. If you look at this one, we can see that we live in a very unequitable world. I just want to mention some of those issues in the top. In the bottom, you can see that almost half of the world population have the revenue of less than $2 a day. Many of them have no shelter. Many of them have no access to college. And now in the health service are responsible to provide 3 dimensions of the health service, which is social, physical, and mental health. So the first point today is how we actually thinking of hospitals and any kind of healthcare environment in terms of fostering and having these 3 dimensions equally and together. That's one challenge. And then when you look at health itself, health is a very exceptional public good. Health is the precondition, outcome, and indicator of sustainable society. So health is not just for the healthcare. Health is not just for having a healthier population. Health is the engine of sustainable society and should be adopted as a universal value and shared social and political objective for all. When you look at health at this way, then innovation brings you some kind of broader meaning. And I think my observation in several countries have somehow shown me that we are not considering health as this capacity, and that's why innovation sometimes doesn't go through. Of course, in the course of last 50 years, 60 years, we have had a number of advances in healthcare and health outcomes of the population. For instance, life expectancy has risen very, very rapidly in many countries. Compared to just, say, 25 years back, 30 years back, 6 million fewer children under the age of 5 die. 25 million people with HIV have access to ART worldwide, and economic and social development has enabled millions of people out of poverty. And when you go out of poverty, then you have better health conditions as well. This is from the Lancet Commission for Health in 2035, and you can see that this has happened because we will be facing a better situation. There are 4 dimensions to that. One is the grand conversion of health is achievable in our lifetime. By 2035, we can see that the child mortality in Zimbabwe could be the same as China, and China as Sweden, and go on. This is great. So we are achieving some kind of achievements haven't been the case in the entire history of humanity. Fiscal policies are powerful for combining communicable diseases, non-communicable diseases, and injuries. So we have a number of fiscal opportunities for innovation. And the returns from investing in health are extremely impressive. So we have economic evaluations showing that when we put $1 on health, we can have better achievements in terms of opportunity cost compared to other things. And last but not least, progressive pathway towards universal health coverage, bringing more people out of poverty and better condition. But nevertheless, we have situations and we have difficulties as well. For instance, people are suffering from non-communicable diseases and communicable diseases. We have complications from pregnancy and mental health, substance abuse, suicide, and this kind of issues. More than half of the world population are still unable to access to health services without financial hardship, and then face rates of high impact emergencies. Look at Ebola, Zika, and other pandemics in the world. And you can see that almost 250 million of the population of the world are displaced, refugees, and others. So you can see almost 3% of the world population, and then 3 million of them are asylum seekers. And this brings us to the condition that we need to think how we are actually fostering innovation in a way that the governance of the health system and the governance of the whole society would change towards bringing these kind of aspects for the innovative pathway toward the healthcare. That's my main point. And of course, health is a human right. Health is a very complex and challenging. I've brought 2 quotes from the current and the ex-Director General of the World Health Organization. All in all means that health is a human right. So when we talk about innovation, this shouldn't be just for the group of privileged people, okay? And then if you look at the challenges of the current world, we can see that the aging population and having access to better care for this aging population, health inequalities is rising, the increasing influence of unhealthy lifestyle. Only in my country, most of people die from what they eat. And I think that's the case for all of your countries as well. And increasing the burden of mental health and things which is about antimicrobial resistance. So this is one of the challenges that we have. And if you look at those small graphs and the shapes in the corner, I have highlighted 2 things. One is when we talk about hospital, any healthcare environment, what matters is how we actually change or transform the governance of the hospital or any healthcare system which can accommodate these kind of changes. To be honest with you, I have visited many countries. In my home country, developed countries, high-income countries, whatever category you bring with, this is not being dealt with in a kind of coherent manner. And the second thing is how we can actually have a kind of equitable health system through this innovation. And that's why we need to address these 3 agendas. One is the unfinished agenda of communicable diseases. So that's why we have neglected tropical diseases and other things, specifically in sub-Saharan Africa and some kind of low-income countries. Demographic changes towards non-communicable diseases and impoverishing medical expenses. When we talk about technology, innovation. Sir Andrew mentioned about drug and expenses of drug and how we can somehow bring more cost-effective drugs and technologies into our health system. Technology is good. Technology is bringing advantages, but it is very costly. And we have this industry pushing us for that. So how we can actually adjust these balances between this kind of pressures from the society. And then, because of that, we need to transform our healthcare system. And my main point today is, in terms of transformation, technology is there. So it's not a matter of technology. It's a matter of governance and how we change our governance in a way to address that, changing in the model of care. One thing which is very important is self-care and integrated prevention. The second thing is the use of technology like artificial intelligence. Do we have the capacity to have artificial intelligence in some hospitals in low-income countries, and how we can use this capacity? And concerns about access of some specific groups, advances in genomics, and then big data. In terms of big data, My third point is this. Big data can transform the governance of health system in dramatic ways. Just imagine in 10 years to come, you can have data which brings everything from all citizens and all population of the country together. So you can look at across the board and you can see that how this human being and citizen looks like in terms of their system. And that's why we need to change the model from industrial age medicine, which was more tertiary care and providing care at the hospitals, towards information age healthcare, which is health in the community and bringing these social aspects of health to the community and where people live. Is technology the answer? Yes, of course technology is a good answer, but something which needs to be attended more is the platform of SDGs provides us with a good transformative governance agenda. And as you know, SDGs are based on 5 pillars, 5 Ps, as we can see in this diagram here. And one thing which is very important is partnership. So my main point is, when we want to talk about the global risks of diseases, the way that we are addressing these health services, we need to bring these SDGs into the agenda, and we need to think of the partnership in a way that bring industry and other parts of the society into the picture. And this is my main point. If you look at this, that's the model that I think in terms of governance transformation we need to look at that. If you see, we have the policies and programs, which is at the bottom of the things and perhaps the most important aspect of that. Then it moves to the health outcomes. So in terms of health outcomes, one is the length of life. So we have better life expectancy. But in the same condition, we need to have better healthy life, quality of life. And how we adjust and balance these two, the model has at least 4 components. Just 20% of that is clinical care, and 30% of that is health behavior. You can see 50% of that is social, economic, and physical environment, which is beyond the boundary of the health system. So my main question to the policymakers in the room and the IHF and all of us in the healthcare is how we can actually balance between these 4 dimensions of the health outcome in a way that we move from the model which we can see from here on the right-hand side to the model which is on the left-hand side, which brings more institutional inequalities and living conditions and social places and social considerations into the picture. In the course of last few days in this conference, I've heard a number of examples like St. Luke in the United States and others, and I guess one main question is, okay, we are dealing with acute patients in the hospital. How we can bring this into the picture? And perhaps this is one of the most fundamental difficulties that we are facing, and we need to address that. And then one main document for that, which I'm really happy, I'm sure many of you are aware of that, is just 1 month ago in the United Nations, this document, Global Action Plan for Healthy Life and Well-Being for All, was launched. This has brought by 12 UN organizations. I think for the first time in the history of the United Nations, these all organizations are working together in order to address the challenges of working together in partnership. This document has many points in that. One is partnership for fostering innovation and changing the governance of health. Just my last point is about in Iran. How we have addressed this in Iran. Iran has a very unique governance of the health system. We are the country, we have merged our medical education into service since 35 years ago. And that's why all of our medical universities are under the Ministry of Health, and all teaching and public hospitals are under the Ministry of Health as well, okay? If you look at this diagram, you can see that this is a very complicated one. But on the other hand, we have the army of hospitals and the health system across the country in all the 31 provinces. I've just bring 4 examples to you very, very briefly. One is 724. 724 is a partnership between the hospitals, the primary care, and the other organizations in the society for thrombolytic therapy for CVA, for people who are suffering from thrombosis in the brain. And this is being in operation in 100 hospitals across the country, and more than 30,000 patients in the course of last 3 years have been saved with this. Another one is 247. 247 is primary percutaneous coronary intervention, which is when you have the heart attack and your EKG shows ST elevation. So there is a mechanism, again, a good combination, a partnership between different parts of the health system. They take you directly to the cath lab and they put you under the intervention therapy. And more than 50,000 patients have been addressed. Another one which my colleague Hamid mentioned is the capacity building for our hospital managers and CEO managers. More than 600 hospital managers and almost 300 hospital CEOs have been trained on this in order to empower them with the capacity and with the knowledge and experience of how to deal with this. And another one is antibiotic stewardship to address antimicrobial resistance and the high use of antibiotics in the country. I'm more than happy to take your question if there was any issues that you wanted to have more clarification. Thank you very much for your attention.
Obviously, we could stay here all day talking about all of this because every speaker has such great information. So our final speaker, before we get to the open dialogue, and I want to remind you to make sure you give us some questions, but it's going to be about really patient empowerment and technology, which we've talked a little bit about today, but not as much as Saad is going to talk with us about. So Saad Chaudhry is the group Chief Information Officer for the Saudi German Hospitals Group in the Emirates. He's going to really talk about this whole notion of all the patient groups, you know, the patient-focused apps, the wearables, all the things that are coming into play here, and look at the prevalence of what's available to empower patients. And of course, that's one of the main attributes of technology. He's coined the phrase leapfrog conundrum, and that's about sort of this notion of how do we leapfrog into the future, doing what's right for patients and leveraging the best of our resources. So Saad, let us welcome you to the podium.
Thank you, Deborah. Thank you, IHF, for inviting me up here. I am representing an organization back home in the United States called CHIME, which is College for Healthcare Information Management Executives. And I say this only because throughout my career, they have helped me a lot. It's an advisory organization for healthcare executives, specifically in technology. And of course, my day job, as Deborah mentioned, I'm the Group Chief Information Officer for Saudi German Hospital Group here, based out of the United Arab Emirates. So we want to talk about e-health and how it provides value to patients. Patients are us, all of us, all the human beings in this room and beyond. But what exactly is e-health? We talk about e-health in a very, very general way. So about 20 years ago, about 2 decades ago, e-health was confined to having a computer in your hospital. If any part of your hospital was operating off of paper onto computer, that was considered e-health. That is clearly no longer the case. Today, at the center of e-health is no longer a computer or a software or a hardware. What it is data. It's your data, it's my data. It's the patient record, the electronic patient record. So all of a sudden, we have gone from centralizing the emphasis of e-health onto the piece of technology to actual information. And so this is a bit of a busy slide, but it really shows you that at the center of it is the collaboration of all these bits and pieces of information that are coming in from your ambulatory setting, your outpatient centers, your hospitals, your home health sort of services, even telemedicine now, and everything else on the side of it, pharmacy data, diagnostics, labs, and these are all the advanced features that we're seeing nowadays, and we've heard a lot in this conference as well. Your wearables, genomics, which ties into precision medicine that a lot of some of the advanced organizations in many countries are looking at. And then going into the healthcare information exchanges. The HIEs are something that a lot of countries are looking at regionally. That is to say that if you have 5 or 6 major hospital organizations, the ability that you can share the data amongst them through a regionally centered HIE is a concept that's been around for about a decade, but is now being implemented in any parts of the world. And lastly, this used to be, I was actually debating if I should put this on the slide, but mHealth, mobile health, used to be its own category. It's no longer the case. mHealth is just another place where you can have a touch point for the regular health technology. So now it's just another touch point on your mobile screen. That's it. It's not a separate category on its own. So how does this empower patients? How does this empower you and me? This is perhaps currently the ideal goal for many of the organizations out there in the United States, in the Middle East, and everywhere else in between. And that is that your data, my data, it's ours. it should be ours. We should be able to take it with us wherever we go. In an ideal world, you should be able to take it beyond national boundaries. In many cases, that's not possible right now unless you take a USB drive or you copy it onto your Google Drive somewhere. But within your own national boundaries, you should be able to take it with you. You should be able to go from one hospital to the next. If you're vacationing in another part of your country, if something happens, you go to a hospital over there, and that physician or that clinician should be able to look you up somewhere and say, oh, I see that you have this critical condition. I see that you're dealing with this in the past. I see that you have this medication. Oh, and you had labs done last month. How does that happen? That goes back to that HIE thing that I talked about, the healthcare information exchange. And what that allows your physician or your clinician to do is no longer dealing with you on a static snapshot way. No longer is your clinician treating you based on what they're seeing in front of them right there and then, or perhaps a lab test that was done last week. They are now treating you in a dynamic, ongoing way because your record is being built at every single touch point, and it's cohesively available to them through an HIE or through other integration possibilities depending on what your national sort of infrastructure is for healthcare and hospitals. And lastly, this is, if we're able to do this, if we're able to bring patient data together cohesively, we can start working towards precision medicine. Precision medicine basically means that, okay, so now we have all this data together. That's great. Your clinician now has a clearer picture. What do we do with it? How do we actually utilize all that data on the patient to actually provide better care? Because right now we would provide the same care just in a more effective way. And that's where precision medicine comes in, because what you now do is saying that, oh, if we bring in your family history into it, genomics into it, perhaps the same medicine that applies to you and your height and your weight and your age may not apply the same way to your neighbor who may be the same exact category because we have all this data on you now. And this data says that you should be treated in this way for this ailment. I'm going to skip over this slide, but it's of course going to be available in the PDF. These are what we consider in this day and age foundations of your modern e-health ecosystem. So these are things none of you are unfamiliar with. You've heard of EHRs, you've heard of the payers providing claim data electronically. I've spoken right now about the HIEs. Unique patient identifiers come into play if you have all those other foundations in place, because then you're able to identify the patient from one hospital to the next, from one part of your country to the next. And of course, at the very end, but not the least, is the information security and privacy. If you have an all-encompassing piece of patient data, that is extremely valuable. That includes not just your demographic information, your identifying information, but also everything about you from a healthcare basis. So this last piece becomes the most important aspect of it. You wouldn't want to trust all your information if you don't really know for a fact that it will be safe. So a few thoughts on how we get there. A lot of organizations have been building their eHealth foundation for many, many years. This is true on a national level in many countries because they mandated that. For example, in the United States, we had a law called Meaningful Use, which mandated the applicable electronic health record technologies at hospitals across the country. So they have a foundation. But there's many countries that don't have that foundation yet. They can leapfrog, which basically means that they can jump over a lot of the other painstaking failures and lessons that everybody else in the world learned and go to something newer right away. But the issue is, when you leapfrog, you're inherently taking a risk. And risk in healthcare is a very, very sensitive thing because we're dealing with human beings. We're dealing with human lives. So, another plug here, use your local organizations, your national, your global organizations, such as Chime, if you're a CIO or if you have CIOs reporting up to you, and if you're thinking about that leap. And so last couple of slides here, I love this picture. This is an actual picture of a race in Turkey. That was between motorbikes, race cars, fighter jets, and passenger jets, right? So if I didn't tell you anything about this race, I said, you have to pick the fastest vehicle. I know I would pick the fighter jet. I would say, it goes Mach 6. You're not gonna go 6 times the speed of sound anywhere else. But and that's what we face. as executives in the healthcare space, what we face is a requirement to pick something and pick a direction for our organization for 5, 10 years without knowing the racetrack. But had you been like me and picked the jet, you would have been wrong, because the bike won. The bike won that race because the parameters of the racetrack were such. It was 400 meters. Everybody started from a stationary start at the same time. So all of a sudden, your jet wasn't worth anything because it didn't have the time to even take off. All of a sudden, your race car couldn't accelerate fast enough to beat the bike. It was a Formula 1 car in there. The bike, the cheapest and what would be seen as the slowest means of transport, was the absolute fastest thing in those conditions. Look at your conditions. Look at your organization. Look at what you're trying to achieve, and look at your national environment, and then make the leap. Leaps aren't bad, but you have to make it thoughtfully. My information is on here. These little icons are clickable when you get the PDF. Connect with me on LinkedIn if you have any questions. I'm always happy to help. Thank you very much.
So now we have a few moments for questions. And we have slido.com, so those of you who have asked some questions. So I'm going to kick things off here, but obviously we invite you into the dialogue for the next 15 or so minutes. So Sir Andrew, I want to start with you because I noticed there were some questions about sort of the overall outcomes of the work that you've been doing. How many drugs have been terminated? You know, what is your sort of assessment when you think back about the 20 or so years that you've been involved with these activities about the outcomes you've achieved, or perhaps the progress you've made in terms of either divesting or investing in terms of saving lives?
Well, very few technologies have been terminated in the sense that we can find absolutely no value at all in them for improving outcomes for patients. So in most cases, we can find that value. It's not everything that companies claim for their products. And so much of what we've heard from all the speakers here is about the need to be discriminating in the use of new technologies and really to understand how they fit in the care pathway. Where do they bring additional value? And it's not necessarily the same in every jurisdiction. It depends on how systems are structured, what their priorities are, where they are in developing individual services, what technologies they've currently got available. Being selective about what you need to improve outcomes is really very important. It's a bit like the leapfrog point a moment ago, that you don't have to assume that everything that's brought to a market is necessarily the thing that's going to make the biggest improvement for patients. Absolutely jurisdiction specific.
I'm curious too, just as a follow-up, about the patient perspective, because it strikes me that it's very challenging to balance the risk and the evidence with the emotion of what's possible in terms of care. Can you give us some thoughts about the patient perspective and how that's integrated, and how do you balance that relative to the art of the work and the science of the work?
Yeah, it's one of the really interesting things about the way we've gone about, and indeed the way any organization, institution, local and national level can go about making decisions about how to develop their services, whether it's a new technology or introducing a new service, whatever it is if you talk to the institutional associations, the national patient groups or even local patient groups, quite understandably and quite properly, they're advocating for absolutely everything that could potentially bring benefits to their community. Mm-hmm. And at an objective level, I'm sure they understand the fact that they've got a claim on resources, and lots of other patient groups have got a similar claim. But that's their job; they advocate. But when you get individual people, individual members of the community, whether they're living with a condition or whether they're just representing the community, it's interesting how that perspective changes. And the representatives that we've got from the public generally and from patient groups on our professional on our independent advisory groups is that they are the most testing and objective in many cases. They'll really hold companies to account for the explanation they bring about their value proposition. And they don't simply default to, we have to say yes because it's something new. Yeah. So it's very interesting. If you get groups behave in a particular way, individual patient representatives on advisory group can often behave quite differently.
Yeah, that's encouraging. Other thoughts, Americo? Do you have a patient perspective, and what are you thinking about in terms of the? Yeah, you have some microphones also down there on the table, just so you know. We can share. But you know, certainly in the context of how you're managing your governance and decision making, do you have a thought about that?
Actually, to collect the patient perspective in a context of decision making in a single hospital, of course, it's a bit challenging. Yeah. Yeah. Let's say, if we have in mind the kind of involvement that we have in an agency such as NICE, or in a national HTA body, where it is possible to structure, of course, a process that is getting the patients associations involved in the different phases, very important in the phase of prioritization of the analysis, also to get the information in terms of patient-reported outcomes in the assessment, and more importantly, probably in the appraisal phase. When you are in a hospital trying to make decisions regarding health technology, of course, you should have in mind that, of course, in another level of the system, you have had information regarding which is let's say, the values, the perception of the relevant patient groups. From a very practical point of view, in that moment, for example, in our case in Gemelli Hospital, we are not collecting the patient perspective, but what we have seen also, that similar approach we have seen in many different hospitals that we have surveyed, that we have collected during this European project more than 50 case studies. And one of the critical points, actually, is how to embody in the decision-making in a hospital the patient perspective in the sense of the kind of involvement that we have at the national level. Mm-hmm. In a hospital, you have the patient perspective because you have the patient in the bed. And that is totally different story. You can take into account in a different manner. And you have to take into account in that manner, is mostly related to the clinical needs that the patients that you have there, or the typical patient that you have in your context, represent, and how the technology can face problems that patient has. So it's
Amir and Saad, maybe you could comment on this notion of partnerships, and certainly in the global scale, the Googles, the Amazons, all of what we would call in the United States disruptors. How are you thinking about those outside influences that may either help us or at least need to be worked with in terms of the work that we do in balancing sort of the national and the local interests? Talk to us a little bit about that.
Go first. Sure. Technology inherently disrupts whenever there's a pain point in a process. So if you think about, let's say, Uber or Amazon, where Uber disrupted it was a pain point for you to take cash out of your pocket, talk to the person driving the taxi and say, hey, give me this much change back, fine, keep this much as tip. Oh, I don't have enough cash on me. Or if the taxi started taking credit cards, you said, oh, the credit card machine isn't working, I have to go to the ATM now. Because these were pain points for people that just wanted to go from one place to the next. And oftentimes the taxi cabs weren't the nicest. They weren't the cleanest. So Uber stepped in, took the pain point away, and there was a pain point on the side where people wanted to make extra income. Done. Win-win on those sides. Amazon did the same thing. Amazon did their payment platform, made it inherently easy for you to buy things in one click, made it easy for you to find things that you thought you didn't even need, but that Amazon said you did, and you go ahead and buy them. I believe that in healthcare, it's going to be a similar thing. Healthcare is it's an inherently sensitive and important piece because it's human care. We're all living and we're all going to need it at some point in time in our lives. But as an industry, it's a retail industry that doesn't really realize it's a retail industry. We make it continuously painful because we feel we are different. And there's so many pain points for me as a patient, for you as a patient, when we go through this process. So technology is going to disrupt that piece. And I believe that's where players like Google and Amazon and Apple are stepping in, because they believe they understand that process in the rest of the industries. I know that in the United States, there is a 50-50 split. Mm-hmm. There's many that believe there's going to be nothing coming out of it except really well-written research papers. And there's others that believe that all of a sudden they're going to be able to use their Amazon payment method at their closest hospital. There are others that believe that their profile that exists in Amazon will now include their health measures and components, and so they can just carry it forward and into the healthcare industry and go to a hospital and clinic. I think the jury is still out. Yeah. But that's where it'll be. It'll be the pain points.
Yeah. Well, there's so many things to balance here, right? The individual interests, the national interests, you know, how do you really manage ethically? There's a lot of questions here about pricing and should we have more of a global approach, because we're, you know, if everybody's doing something separately, we're not really getting the benefit of a global benefit for all, right? So Amira, I hope that you will, we're going to have to come to a close, but I want to ask this question of each of you. But if you were to think of one word that would capture what leaders really need to be paying attention to, it can be a skill, it can be, you know, an agenda for the country. What is the one thing that you really think is critical for leaders to really think about in this context?
I think I just repeat what I said, which is about transformative governance and understanding that the world has been changing and will be changing rapidly. And going back to the first question, for instance, about data and the partnership about data, what matters is we need to understand data, patient's data is patient's data. It's very confidential, but it is a property which can be used for the better population health. So that's why we need to think of this issue very critically and keep the confidentiality of data very vividly, and at the same time think of some partnership ways. I mean there is no magic formula for that, but thinking of partnership ways that we can have the data shared across the board in a way that we can provide a better population health. Just one simple example. Facebook was under scrutiny because Cambridge Analytica company for the presidential election in the United States, and the data was shared. I was thinking exactly the opposite, how we can actually use the data which is captured by Facebook and other social media organizations in a way that the confidentiality is observed, but many habits of people, ordinary citizens, which cannot be captured in an ordinary way, can be used for the better health. This is a leapfrog to somehow use the partnership between different companies, entrepreneurship and social media for the better health of the population.
Yeah. So, Sir Andrew, one watchword for leaders to think about relative to this topic.
Partnership. Key word, I think, it's shifting the relationship between life sciences industry, or indeed any of the industries that are bringing technologies of any description that might disrupt and then ultimately have benefits for the way we deliver services to patients and improve the outcomes that we get. But shifting from a sort of conventional, historical supplier-customer relationship to one in which there's a genuine partnership that requires both parties to understand the ambitions and constraints that they've got is a really important and effective way of improving the use of resources, managing disruptive new technologies, and improving outcomes for patients.
Excellent. Americo, any one word or Saad, and then we need to close because we're out of time.
My quick one word is equity, because one of the challenges of technological innovation is the the availability
yeah.
of these innovation, the opportunities
yeah.
for patients.
That's very important.
We have data, for example, in my country,
yeah.
in which is it very clear how different territories provide different access to patients for the same innovation. I think this is something to really be careful to look at.
Equity.
Transformative governance.
Transformative governance, Saad?
So I'm going to borrow a little transformation, just transformation. And the reason I say that is because all of us are going to have to transform, but we're going to have to do it in different ways. That leapfrog conundrum I talked about, you're going to have to understand your racetracks. Some of the transformations are going to be heavily in technology, but some are going to be in governance, how you make decisions. Some are going to be in your processes, your medical workflows that are going to adhere to these newer technologies coming in. But the transformation is going to have to occur either way.
Let's give our panelists and Surendra a big round of applause.